Was asked to share some things about the Medmont topographer, and I thought that maybe you'd enjoy hearing about one of the more recent studies that really explains how we can understand the myopia control signal in ortho-K. And this was a study using the Medmont topographer. So let's start. And one of those things that you might ask is, how do we analyze ortho-K outcomes? And of course, we know that we check the slit lamp signs, we check the corneal health, we check the visual acuity, and then we do topography. So simple. But how do we check the myopia control efficacy? How do we determine if the lens that we just dispensed is going to produce a signal to slow down eye growth? That's not so simple. One of the ways that we primarily use, of course, is to do biometry and compare the axial length today to the axial length long into the future. But there's no way to tell if the lens that we dispense today is actually going to produce enough signal. We need some way to be able to analyze right up front in the earliest days of ortho-K, how effective is that lens? So is there some method that we could use to do that? The tangential map we know is most effective for determining the position of the lens in the closed eye environment. It's helpful to determine the treatment zone size as a concentric ring, but it's really not ideal for measuring the treatment zone of the eye. It's really best at determining, does the lens position centered? Is it high? Is it low? That's its principal function. Nothing visual is the tangential's strength. The axial subtractive map, of course, is very effective at determining anything related to vision or power. And one of the most simple functions is for us to click on the visual axis on the center of the topography, and it'll tell us how much RX change have we created, how much effect has ortho-K created. It's effective at determining the treatment zone position, a little more accurate than the tangential map would be. So we know the treatment zone position relative to the pupil, relative to the visual axis. We know the treatment zone size relative to the effect that we're creating. So another very important piece, all related to the axial subtractive map. Now, finally, how do we learn something about the signal that we're creating? We know if we've created a bullseye topography, if we've created the ideal centered effect, but have we created a good myopia controlling ortho-K outcome? Here's an example where I'm happy with the centration. It's a little bit high relative to the visual axis here, but am I happy with the myopia controlling outcome that we've created? So one of those things that we've done for the last 15 years is focused in on the topographical effect within the pupil. This area here within the graph, within the pupillary diameter. And then we determine what is the RX change on the visual axis at the center, what's the RX change at the pupil border, and the difference would be the defocus signal, or what we've called the myopia defocus dosage. In this case, it's approximately 2.72 diopters. Is that enough to create a signal to slow down eye growth? That's the question that we wanted to ask. So we went to colleagues at the Hong Kong Polytechnic in Hong Kong, names that you'll probably know, like Pauline Cho, who was the first researcher to tell us that orthokeratology lenses are effective in children in slowing down eye growth. Her LORIX study in 2005 was the first to give us true indication that ortho-K lenses are effective for myopia control. Her colleague, Kiki Tan, was her PhD candidate, and she has done numerous studies on orthokeratology and atropine to determine whether the combination works more effectively or less effectively in myopia control. And Stephen Vincent is a very famous researcher from Queensland in Australia. So some very experienced orthokeratology researchers that were involved in this study. And what they compared were two separate studies. I know this will sound crazy, but they were two different studies. One was the VOLTS study, and one was called the AOK study. Both performed at Hong Kong Polytechnic, and both performed using the Medmont and using the same design of ortho-K lens. The primary difference was one of the groups was fit in the 5 mm optic zone. The other group was fit in the 6 mm optic zone lens. So both the same lens, both fit with the same protocols, just with the different construction of the optic zone. And we looked at the 2-year data that we had retrospectively on both the VOLTS group and the VOLTS plus the AOK group. So all the patients in the VOLTS study that had a 5 mm optic zone, all of the patients in a 6 mm optic zone between the AOK and the VOLTS study. So then the idea was to determine, can we learn from their topographies before we started ortho-K versus after 2 years of findings to determine, is there any way to measure the signal strength and how much axial growth we were able to control. So the study period was this. It took both studies that had subjects that completed 2 years of findings. We looked at the topographical shape before ortho-K, the baseline topography. Then we looked at the effect after 1 month of wear in ortho-K, and then 2 years of ortho-K. So we have both the baseline findings of biometry and the baseline findings of Medmont topography, then the 2-year findings of both topography and biometry readings. Now we looked at the topographically in the Medmont, we looked at the flat meridian myopia defocus dosage, meaning what is the difference between the apical effect and the effect at the pupil border at a 5 mm pupil along the flat axis of the eye. Then doing the same thing, comparing the apical change versus the power at the pupil along the steep axis, and then the apical change versus the average power across a 5 mm pupil circumferentially. Next was to look at the aberrations, and these are not ocular aberrations. These are the anterior surface only. So aberrations we could measure with a Placido topographer, with the Medmont. So we were curious, can we use the HOAs, the high order aberrations measured by Medmont, to predict the axial growth that was likely? Then another thing that was looked at was the volume of power. In other words, when you take all the powers that are distributed within the pupil, what does that total value come out to, and could it be predictive of axial growth? Then the final was to look at the cone. If you imagine a cone of power that is created by orthokeratology, more effect in the center, less effect as we go out to the periphery, and determining that differential between the peak of the cone and what's happening in the center. So all of these metrics were studied to determine which one could most accurately predict eye growth in children. And as it turned out, very few of these analyses options were truly effective at picking out a difference in the two optic zones used and in the children that were having good myopia control and less than ideal myopia control. It works out that the two that were most effective were the volume of power and the circumferential myopia defocus dosage, the cone of power. So these two were most effective at determining which patients would have a good effect from myopia control ortho K and which ones would not. So taking a look at what our topographer can tell us, we can get some indication from the myopia defocus dosage, the MDD of the flat, the steep, the circumferential, and the HOA. It can provide some weak signal. It's not profoundly strong enough or significant enough to tell us the whole story. If we use our topographer and measure the volume of power, or what makes the most sense to me is the fitted circumferential MDD, because this is like an add power. It would be plus 250 as an example, where it's more similar to what we think of in soft multifocal lenses. What is the add power we're applying to this patient? What is the defocus that we're applying to this patient? So this study was just published in January of this year, and it's one that you can look up to learn more. If we had more time, I would be happy to explain more, but I know we have so many topics to cover today, and I'm just happy that I had a chance to share a little bit about this research, because for the first time, we now have the ability to perform ortho K on a patient and then measure the signal within, let's say, 2 weeks to a month, and determine, do lens changes need to be made to this lens to provide more signal for this patient? Are we getting a good ortho K outcome, but a poor myopia control outcome? We don't have to send the patient away for 6 months or a year to find out whether the lens is going to do a good job or not. So very exciting study. Now, Marcus gave us some introduction to the Medmont, and I just wanted to reinforce what he said, which was so true. You saw such beautiful imaging from Marcus, and there's basically two versions of the Medmont, the Meridia Classic and the Meridia Pro. They both share all the topographical analyses that share the same axial, tangential, elevation topography. They can both use the contact lens software to build lenses. They both have the tear film surface quality analysis, so they can analyze the dry eye measure of the tear film. So both of them are the same in what they share in their topographical analyses. The principal difference is the Meridia Pro has the ability to do white light, mybography, and fluorescein imaging in images and video. And for us at the university, the Meridia has become a virtual replacement of the slit lamp in our education. Now, I mean that specific more to contact lens. Of course, nothing replaces the slit lamp. But as Marcus said, as an imaging device, the illumination, the depth of field, the resolution of this instrument is just so incredible. So if you're looking for a topographer that is a fabulous tool for orthokeratology, is a awesome documentation device for imaging both contact lenses and dry eye, the Meridia is really a very impressive instrument. So thank you everybody for this time to share this study with you, and thank you to the Swiss Lens team.